Welcome to StudyNeuro, your quick daily boost in neurosurgery. In today's session, we're exploring encephalocele, a congenital skull defect where brain tissue and meninges herniate through an abnormal opening. We'll simplify its types, causes, diagnosis, and management, essential knowledge for every neurosurgery trainee. In this video, we'll cover encephalocele in a clear, structured way, from its causes and types to diagnoses, complications, and management. By the end, you'll understand the key concepts, clinical relevance, and principles of care for this important neurosurgical condition. By the end of this session, you'll be able to define encephalocele, understand its main causes, and classify its different types. You'll also recognize the key clinical features, know how it's diagnosed through imaging, and outline the main principles of surgical management and prognosis. Encephalocele is the herniation of brain, meninges, and cerebral spinal fluid through a defect in the skull and dura. It commonly results from failure of neural tube closure or mesodermal ossification during the 3rd to 4th week of gestation. Lesions may be congenital, often associated with multisystem anomalies, or acquired. Congenital forms are typically multifactorial, involving both genetic and environmental factors. The anatomical location largely determines clinical presentation and surgical planning. Encephaloceles occur in an estimated 0.8 to 4 per 10,000 live births and account for 10 to 20% of all cranial neural tube defects. Incidence is higher in sub-Saharan Africa and South and Southeast Asia, and lower in Western Europe and North America, thanks to folate fortification and prenatal screening. Anatomically, occipital encephaloceles are the most common, accounting for 70 to 80%, followed by frontoethmoidal types at 13 to 15%. Parietal and sphenoidal encephaloceles are rare and often syndromic. There is a slight female predominance, with midline lesions being most common and lateral types rare. Regionally, occipital lesions dominate in Europe and the Americas, while frontoethmoidal lesions are more common in Southeast Asia and Sub-Saharan Africa. Congenital encephaloceles typically result from failure of neural tube closure or mesodermal ossification during the 3rd to 4th week of gestation. Developmentally, neural tube defects create persistent communication between neural and surface ectoderm, while mesodermal failure leads to incomplete cranial bone ossification and bony gaps. Genetic syndromes like Meckel-Gruber, Walker-Warburg, and Chiari malformations, teratogens such as folate deficiency, hyperthermia, maternal diabetes, and valproate, as well as nutritional and geographic factors, all influence risk. Acquired encephaloceles can result from trauma, such as skull fractures, neoplasms causing chronic pressure or invasion, iatrogenic causes, including surgery or radiation, infections or inflammatory conditions like osteomyelitis or tuberculosis, and occasionally, idiopathic or spontaneous defects. Encephaloceles are classified based on anatomical site, size, contents, and laterality. The major anatomical types include 4 primary categories: occipital, frontoethmoidal, parietal, and basal. Encephaloceles can be classified based on lateralization. Midline lesions like occipital or frontoethmoidal are most common and usually isolated. Lateral lesions, such as lateral parietal, are less common and may suggest syndromic associations. Encephaloceles can also be classified based on size. Small encephaloceles are smaller than the head, usually less complex surgically, and may contain only meninges, CSF, or small brain portions. Giant encephaloceles are larger than the head, often include significant brain tissue, carry higher surgical risk, and are commonly associated with microcephaly, hydrocephalus, and severe neurological deficits, especially in the occipital region. Encephaloceles can be classified based on their content. A meningoencephalocele contains CSF, meninges, and brain tissue. A meningocele contains only CSF and meninges. Atretic encephaloceles, usually parietal occipital, contain dura, fibrous tissue, and degenerated brain and present as subscalp swellings. A gliocele is a glial-lined cyst with CSF only, while a meningoencephalocystocele involves herniation of a ventricle into the sac. Encephaloceles are classified based on location according to Swanwella and Swanwella. Occipital types often involve vascular structures. Cranial vault lesions, making up about 80% in the Western Hemisphere, include interfrontal, anterior and posterior fontanelle, interparietal, and temporal regions. Frontoethmoidal or Occipital encephaloceles account for 15%, with defects at the nasal frontal, nasal ethmoidal, or nasal orbital regions. Basal lesions, rare at 1.5%, protrude into the nasal cavity, sphenoid sinus, nasal pharynx, or orbit. Posterior fossa encephaloceles usually contain cerebellar tissue and ventricles. Clinical presentation varies with the location, size, and contents of the sac. Typical features include a midline swelling or protruding sac at birth, often decipital or frontoethmoidal. Neurological signs may include developmental delay, seizures, or raised intracranial pressure. Facial anomalies like hypertelorism or nasal obstruction occur in anterior types, and basal lesions may present with CSF leak or meningitis risk. Associated anomalies are common and depend on lesion site. Frontal encephaloceles may accompany microcephaly, cortical malformations, or cysts. Occipital types often associate with Dandy-Walker or Chiari malformations and callosal agenesis. Spinal anomalies like dysraphism or vertebral defects may also occur. Craniofacial anomalies often accompany encephaloceles. Frontal lesions may present with median cleft face features, hypertelorism, midline cleft lip or palate, and dermoid cysts. Syndromic links include Meckel-Gruber with polycystic kidneys and polydactyly, and Walker-Warburg with lissencephaly, muscular dystrophy, and ocular defects. MRI is the gold standard for diagnosing encephalocele. It divines the location, size, and contents of the sac and reveals any associated brain malformations. Key sequences include T1, T2, FLAIR, coronal T2, and magnetization prepared rapid gradient echo, or MPRAG, a high-resolution 3D sequence ideal for structural detail, along with MR angiography or venography. MRI also helps differentiate encephalocele from nasal glioma or dermoid cysts, guiding precise surgical planning. CT scan is essential for assessing bony defects and ossification, providing detailed 3D preoperative planning and complementing MRI, especially in sincipital and occipital encephaloceles. Ultrasound serves as a quick bedside tool in neonates, helping detect ventricular dilatation and major brain anomalies early. Systemic screening helps detect associated anomalies in encephalocele. Renal ultrasound checks for polycystic kidneys or agenesis. Urea and creatinine assess renal function. Echocardiography screens for heart defects, while chest imaging evaluates airway or lung abnormalities. A skeletal survey identifies limb deformities or polydactyly. Genetic testing, including karyotype CMA or NGS, detects mutations like CEP290 or MKS1. Eye and hearing tests, such as fundoscopy, VEP, and BAER, assess sensory function, and endocrine screening checks hormones like cortisol, TSH, and GH in basal lesions. Complications of encephalocele vary with location. Posterior or occipital types often lead to hydrocephalus, cerebellar dysfunction, visual loss, and poor neurodevelopment, with added risks of CSF leak and infection. Anterior or frontoethmoidal lesions can cause facial deformities, CSF rhinorrhea, airway obstruction, and cosmetic issues. Basal or transsphenoidal types may present with respiratory distress, feeding difficulties, and delayed diagnosis. Early detection and prompt management are key to preventing these complications. Treatment of encephalocele is primarily surgical. Early intervention prevents infection, hydrocephalus, and facial distortion. Surgery involves excising the sac and non-functional brain tissue, reconstructing the skull defect, and managing hydrocephalus with a shunt when necessary. Approach depends on the site and size of the encephalocele. Open transcranial is used for large or intracranial lesions, while endoscopic transnasal offers a minimally invasive option. Transsphenoidal access suits select cases. Occipital lesions require sac excision and cranioplasty. Sincipital ones need bifrontal craniotomy with base repair, and basal types are managed through frontal craniotomy with intradural repair. Prognosis depends on several factors. Occipital encephaloceles have poorer outcomes, while frontal ones fare better. Small sacs without brain tissue do well. Large, neural-filled sacs carry higher risk. Untreated hydrocephalus, associated malformations and infections, worsens outcomes. Preventing encephalocele begins before birth. Folic acid supplementation during pregnancy is key to reducing neural tube defects. Early diagnosis and prompt surgical repair help avoid complications and improve outcomes. In selected cases, cesarean delivery can also minimize trauma to the baby's head, and infections worsens outcomes. Let's look at the differential diagnosis of encephalocele. For occipital or posterior encephaloceles, the key differentials include dermoid or epidermoid cysts and posterior fossa cystic tumors. For frontoethmoidal or anterior encephaloceles, important differentials are nasal glioma, nasal dermoid cyst, and midline nasal polyp or teratoma. Encephalocele is a rare congenital cranial defect that arises from the failure of neural tube closure or mesodermal ossification. Its presentation and prognosis depend on the site, size, and neural content involved. Magnetic resonance imaging remains essential for accurate diagnosis and surgical planning. With early detection, timely repair, and a coordinated multidisciplinary approach, survival, neurological outcomes, and quality of life can be significantly improved. Thanks for watching. Don't forget to like, share, and subscribe to StudyNeuro for more clear, high-yield neuro content every week. Share your key takeaway below and stay tuned for more neurosurgery made simple.